Today's lesson will take on a detailed journey through the fetal heart embryology from conception to circulation. The objectives we will discuss: number one, understand the stages of fetal heart development. Two, we will identify some key factors in the developing heart. And three, we will explore common congenital heart defects and their origins. First and foremost, the cardiovascular system is the first system to develop. Okay, and it starts its development through the embryonic stage, which is through weeks 3 through 8. This is the most sensitive and vulnerable stage. During this stage, you will have the development of both the heart as well as the central nervous system. Okay, so it's a very important stage. Notice the central nervous system will continue to develop throughout the fetal stage, where the heart is completed by week 10. Okay, so I did want to point that out. Now, the factors that can affect the heart formation, there's several. So, starting with some genetic changes, chromosome abnormalities, so T21, T18, T13, and various others. Environmental factors can play a part, medications, health conditions, as well as various other pregnancy risk factors. To know in detail what these risk factors would contribute to a particular congenital heart defect, I do recommend you refer back to my lesson one, because I really break that down in that lesson. Okay. All right, so let's get started. So our heart, of course, it goes through a complete formation process. So the heart starts off as a peritubular structure. This is important to know for your boards. So we start off with a peritubular structure. Blood flow is flowing up and down. And from that, it's connected by the vitelline veins as well as the umbilical veins. Now, we'll discuss more when we get to our venous development system, but the vitelline veins play an important part in the development of the portal and hepatic veins as well as the venous system. All right. As for now, we can just talk about what is its formation during this process. So initially, you can see here the umbilical vein job is to drain the chorion. From there, you have your vitelline veins. They're going to drain the yolk sac. And then the cardinal veins job is to drain the remainder of the embryo. All three plays an important part in developing the portal and venous systems. Very important, and we'll get to that at the end. All right, so let's first discuss the umbilical vein. What is its purpose? Is it a left umbilical vein present? Is it a right umbilical vein? So we're going to just kind of break that down, okay? So the umbilical artery's job is to carry the deox blood away back to the placenta, where the umbilical vein carries the newly oxygenated blood and the rich blood and all the nutrients that the fetus will need towards the fetus. Okay, so first and foremost, that is its job. Okay. Now, during early development, the umbilical vein, there's two. There's a right and there's a left. Okay. However, later on in the development, what's going to persist will be your left vein. Okay. So that's what we see during our ultrasounds. Okay. So normally in normal development, the right umbilical vein will go away or regress, and then the left should persist. Okay. But what happens if the right persists instead of the left? Because it happens. And that is called persistent right umbilical vein. Okay. So normally, as you look here on the right, here's your stomach. You have your aorta, you have your IVC, and then you have your left umbilical vein going into your portal vein. Okay, so this is how it normally should look. It should courses towards the right side. Now, the reason why we say left, and I do want to point that out, notice the entrance of this umbilical vein is on the left side, which is with the stomach. Now, compare that to an example of the right. This is a persistent right umbilical vein. Notice its entrance point is on the right side with the IVC. Okay, so it's entering in on the right and it's coursing towards the left, which is towards the stomach. This is abnormal. Okay, this is an example of a persistent right umbilical vein. Okay, so moving on. So in the early development, as you see here in the demonstration, the heart is evident by a noticeable heart bulge, which you can see in the front of the embryo. Okay. Now, from this tissue, because you know about our germ layers, our three germ layers, the embryonic tissue for the heart is coming from the mesoderm. Okay. Now, that's part of one of the three germ layers. And it starts or begins near the head, which you can see here. And that is known as the cardiogenic region. Okay. So, this is a great example of that heart bulge. Right away, when I saw this, I thought of this defect here, the ectopia cordis. Now, with this defect, it's rare, it's pretty rare, but what's happening is that the heart is located either partially or fully outside of the chest cavity. So during development, something went wrong where that heart is positioned outside instead of within the chest wall. Okay. A lot with these cases, a lot of the cases is unknown, but some theories states that it's due to the abnormal development of the chest and abdominal walls. Okay, so normally the lateral body walls will fuse at the midline and it will form that ventral front wall, okay, to kind of position that heart in place. So here's an example of that, where that defect error happened. Okay, now there are key steps in the formation. This is just like a summary of what we're going to discuss. We're going to really break down each one of these stages, but starting from the top, which we kind of discussed already, the heart development is through the formation of the three germ layers, the gastrulation, which we saw, the mesoderm, and then we're going to establish our fields, our first field and our second heart field. From there, we have a tube. We'll go through a looping process. We're going to go through some septation, some spiraling. It's going to happen. This is where we develop our outflow tracts, our valves, our vasculature, and then our conduction system. So it's a very intricate process, very delicate. And so we're going to kind of break down each one of these steps. Okay, now let's start back at stage one. Okay, so we're going back to stage one. We start off with that tube. I was lucky enough to get a example of this tube here. So I mean, it's just pretty. It's so satisfying to see this. But anyway, so you start off with that tubular structure. It forms a single, slightly bent heart tube, and you can even see the slightly bent in my demonstration. Now I have positioned right at the top, which is the head, and left. This is going to become very important when we get to the looping stage. Okay, so just remember right at the heart, at the top of the head, actually, sorry, right at the top of the head, left is at the bottom. Okay, the left, I guess you could say deviation. But so the cephalic portion of this tube is what's going to connect with the arch. Think of your aortic arch. That's at the top near the head, where the caudal portion will connect with your venous system. Right away, you want to think, where is your liver? Where's your liver? Your liver is towards the bottom. Okay, so that should be easy to remember. So cephalic near the head connects with the arch, caudal portion, venous system, think liver. Okay, just think that location. Okay. All right. I do want to point out before we go to the next slide, with the illustration here, we all know this. We're pretty well experienced when it comes to red is the oxygenated flow, blue, as demonstrated, would be the oxygenated blood flow, and then purple is where the gas is exchanging, the mixing of the blood. All right. So with the fusion of that tube, it starts off with the cardiogenic fields. Okay. And we're going to break that down. That's going to be your first heart fields, your secondary heart fields. Okay. That starts right about round implantation, a little after that. So you can see in between weeks 3, 4, and 5. Now, luckily for your exam, I didn't recall them asking too much about what's happening during what week. I mean, it doesn't hurt to be familiar with these steps and what's happening at that time frame, but I didn't recall having too many questions about that. Okay. All right. Now, what I do recall having a few questions about what structures belong to what field. So you want to be familiar with where is what. Okay. So in your first heart field, which you can see demonstrated in the red, that includes your left ventricle, your atrioventricular canal, and your atria. Okay. Now, your second heart field is broken down between anterior and posterior. So, your anterior second heart field includes your right ventricle, your proximal outflows, your distal outflows. Your post is everything else. So, your atria, inflows, sinus venosus, SA nodes, and so forth. Okay, so here's a demonstration of that. I really like this illustration because it shows you the first heart field, second heart field, and then shows you what structures it become, which is important to know. And so you can just see the complete formation process of these fields. Okay. All right. So let's talk about this heart tube in a little more detail. You will have a question or two asking you about these structures. Okay, so keep in mind knowing aortic roots forms the arteries of the aortic arch. Your truncus. Your truncus is involved in the formation of your pulmonary trunk and your aorta. Very, very important. The bulbus cordus is involved in the formation of the pulmonary trunk and aorta. Okay. Now the primitive ventricle forms the ventricles. The primitive atrium forms the atria, and then you have your sinus venosus. Okay. So let's take a look at this. These structures are important to know. You have to know the embryological structures and what it will become. It's very, very important for your exam. Okay, I did have a question or two on that. So once again, you can see, please know this chart and be familiar with this. Okay. I do want to point out that the truncus arteriosus is the distal portion of the bulbus cordus. So I did want to point that out here. Okay. Also to note, the cephalic portion of this heart tube with the developing arch system and the caudal portion with the development systemic venous system. Okay. So, and we saw that. I do want to point out, I want to go back to here where you saw that here, this is where your aorta is. So that's your upper systemic circulation. Okay. And then you have your descending aorta coming down, lower systemic circulation, and then, of course, the pulmonary circulation. So I just wanted to show you that again. Okay. All right. So now we're getting into stage 2. This is where our looping is happening. Okay. So during this process, during the cardiac looping, the primitive ventricle is going to move downward to the right, while the primitive atrium moves upward and to the left behind the ventricle. Okay. This is important to know what is happening. Okay. So it's taken on a right. Very important. This is maybe a test question. So this is normal development of the cephalic portion. I love this demonstration where you can see that. I'll, I'll show that one more time. So that cephalic portion of the heart tube is bending towards the right, where the caudal portion takes on that leftward direction. And from there, a common atrium is formed. Okay, and we're going to learn now that that common atrium is the truncus. Okay, so here's another illustration of that. It takes on like a S shape almost, as you can notice here in the demonstration. Okay, so please, please, please keep this in mind. This formation is the atrioventricular valvular loop. The cephalic portion is bending where? It's bending towards the right. The caudal portion is bending towards the left. As this loop is formed, then we have a common atrium. Okay, please remember that. Okay, so once again, normally cardiac lupin is to the right. This is known as D-lupin. If there is a left loop instead, this is where the defect comes. The congenital corrected transposition of the great arteries is formed because there was an L lupin, a leftward lupin, instead of a rightward lupin. May have a question on that, so now you know. If there is improper division of that common atrium that we discussed after the lupin happens, so they call that a detransposition, improper division of the truncus arteriosus / common atrium. Okay, so that's what happened there in that process. All right, so stage 3. Stage 3, we're going to go back to when we were talking about the truncus arteriosus, because with the separation of the atriums, the ventricles, and the outflows, when all that's happening, guess what? Same with that common atrium. So it's almost like a simultaneously thing going on. So they coincide with one another. So we're going to talk about more about that truncus arteriosus, okay? But during this stage 3, your septums are forming. Okay, so you're going to have your interatrial septum, your interventricular septum is forming. The heart is dividing. So we started off with 2 chambers. Now we're going to break it down to 4 chambers. The pulmonary veins are being formed during this stage. Your AV node and your SA node is developing within the right atrium. That's where they are. Your placental circulation is beginning. Okay. Endocardial cushions is developing, and your mitral and tricuspid valves are forming. That's a lot. This is a lot going on with this stage, okay? All right. So your endocardial cushions, let's talk about that division. So this is the first division in all this process of stage 3. The endocardial cushions begins into the separation of the heart into the right and left, upper and lower chambers, okay? Now the chambers will become the atrias and the ventricles. That's where these chambers are forming. So remember, we're going from 2 chambers to 4 chambers, okay? Now, while the endocardial cushions are continuing to develop, then your atrial and your ventricular septum is beginning to form, okay? So it's like happening together. The demonstration is showing that again. We have a few more other good demonstrations coming up as well. Okay, so let's go. And you see how they're separating the truncus and your septum forming into atrial septum. All right. So let's first keep talking about the endocardial cushions defects, okay? So here's an example of the AV canal. AV canal endocardial cushion defect is also called AV canal or septal defects, okay? So how that is forming, there's 4 large tissues. I try to simplify this process as simple as I could. There's 4 large tissue cushions in the AV canal. They come together to form part of this membranous portion of the septal wall. So this is the crux of the heart, okay? This is where we connect to make the center of the heart. I feel like it gives the integrity of the heart, or the foundation of the heart is this crux portion. Okay, so it's very important for this to form properly. Okay, so from there, you separate the heart ventricles, the openings from the mitral, which is the left, tricuspid, which is the right. These cushions help create these valves. When these cushions don't develop properly early on, then it's going to lead to defects in the center of the heart. Okay, makes sense, right? All right, so just now we're getting to the formation of the septum, interatrial septum. So as you see, initially we start off with that interatrial connection or the communication, as you see there. Here's the endocardial cushion. Now from there, it takes on a process where it starts forming in that septal wall. So it starts off initially with septum primum, foramen primum. Remember, primum is like first, so that's the beginning. It starts off with that, and then it elongates, which you can see here. I love this demonstration. And then from there, you have your foramen secundum. So secundum, think second. So that's two. So septum secundum. And then eventually it will fuse. You see there? It will fuse with the septum primum. Okay. Now notice there is still opening there. That's your foramen. That's normal to have that separation there of the foramen ovale. Okay, so let's take a look at that happening. Take a closer look here, okay, where you can see, kind of, if you could look at both at the same time, where you can see the primum, the secundum, and all that forming, and then it will eventually connect, and then you will have your foramen. Okay, I'll show that one more time. I love this demonstration. I'm a visual person, so seeing this, it helps. It really helps. Um, because sometimes when you read how it's happening, you don't get it, but just seeing this demonstration, it really puts it all into perspective for me. Okay, hopefully for you as well. This the last time. Okay, perfect. All right. So as we saw that process with the interatrial septum, you have the initial phase, the second phase, then the final phase. So of course, if there's some disruption in any one of these phases, then you're going to have a defect. So an atrial septal defect is the third most prevalent congenital heart anomaly, and it depends on where the defect happened or the disruption happened. That's where your, I guess you can say, your septal defect is. So if it's in the, I guess here, I could say patent foramen ovale, we know that's through the foramen. If it's ostium primum defect, we know where that happened, as well as ostium secundum, sinus venosus defect, coronary sinus, and then common atrium. Those defects happen at the location site of the disruption. Okay, so that's pretty like self-explanatory there in that process. All right, so just to break this down, and this is in my congenital heart disease, I believe section 1, where it really goes more in depth with the ASD's defects, but just to break it down again. So with your primum ASD, the hole called the foramen primum didn't close. With your secundum ASD, your foramen secundum didn't close. So it's just, self-explanatory there. And then patent foramen ovale, we know once the baby is born or fetus is born, it should naturally close. In cases where it don't properly close, then that's known as your patent foramen. Okay. So this is pretty self-explanatory with these defects here and what went wrong. All right. Now, the process of the atrials or the atrium septum and the ventricle septum is different. Okay. And so now we're going to break down the ventricular septum. Okay. Now we know here, just to go into the illustration, the atrium is usually split into the right and left chambers by it's a process called septation. The ventricle is divided into the two chambers by the intraventricular septum. Okay. Now, these processes are different. So, the atrial septation is an active process, but the division of the ventricles is more passive. Okay. So, we're going to break this down. It's a little more complicated with the ventricle septations here. Okay. Now, because the formation of the septum is more complex, it it leads to defects commonly happening. So VSDs is the most common type of heart defect due to this complex process. Okay. Now, it's a lot going on. Remember, you have your interatrial septum, you have the truncus trying to split, the endocardial cushions is trying to come together, as well as the septal wall. So if there is an error somewhere, it's going to lead to a defect in your VSD. A lot of times, too, we're going to discuss coming up is that with the truncus arteriosus, if it doesn't separate properly, automatically it usually has a VSD present. Okay, because it kind of works together in the formation. Okay, now let's discuss VSDs. VSDs is just like how with the interatrial septum, wherever the defect is where the error happened. And so in these cases here, you can see the different locations of the VSD. Now, you may have a question or two, you may even have a picture asking what or which defect is present. So it's very important. Now, I do find the two that often get mistaken as the same, or I guess confused, is the inlet VSD and the perimembranous VSD. Okay. And I want you to pay attention, and that's here in D and E. Pay attention to what actual picture we're looking at with the heart. Okay. So with D, where it's demonstrating the inlet VSD, we are at a 4-chamber view. You can actually see it here too. Okay. So we're at a 4-chamber view. The defect is here. Okay. So that's where we're seeing the communication between the two ventricles. Now pay attention to the perimembranous. You almost think it's the same. Like it looks like it's in the same area, but notice we're kind of off, or not, I wouldn't say off axis, but we're more at our 5-chamber view. So here you're noticing with the LVOT or the outflow tract, and your defect is almost adjacent to the aortic valve. So now you see the difference? Notice you don't see the aortic valve in the inlet demonstration. It's just your 4-chamber view. But here at the perimembranous, you notice the aortic valve because it's at that like 5-chamber LVOT view. Okay. I like how with this demonstration too, in different views, you can see where that same VSD disruption happened, how it would appear in another view, which you see with the inlet VSDs, you will see it also in the short axis view. Muscular, looks like it's pretty much demonstrated in all views. And that is the one usually you will have to demonstrate it in another view to confirm that is truly is there. You do not want to confirm or say there is a muscular VSD without in the apical view without demonstrating it in another view. You almost need other views to confirm. Another confirmation of the VSDs would be the blood flow. Okay, so we know with the VSDs, there is a communication between the right and left ventricle. So you should see the blood flow communicating in diastole and systole. You should see a red, blue, and that shows that there is communication during both phases of the cycle, cardiac cycle. I do want to point out that trabecular also is for muscular. So on your exam, they may try to switch the two sayings, but know that it is the same. Okay. I also want to point out before we move on, your outlet, your outlet and your, looks like here, both outlets, supracrystal, infracrystal, is only seen in that high short axis view. Notice? That's why that view is still a good view to look at. It's very hard and tricky. And remember my step-by-step echo, we discussed that high short axis view. So from that view, this is where you will see these septal defects. All right. So let's talk a little more about this septum. So during the ventricular septum and the wall foramen, during this time, notice in the demonstration there is a spiraling happening. The spiraling is with the truncus, okay, and that's separation. So one thing I want to for you to remember, this spiraling process is going downward. Okay, so it's going in a downward direction to meet the muscular wall, and then it's gonna go back to the bottom. Okay, and this is very important because if this process does not happen properly, it's gonna lead to a defect that we commonly see. Okay, so once again, just remember it's gonna go downward, and then the inner lining grows from the back to the bottom. Okay. All right. Now, with this spiraling process that we just saw in that demonstration, it's due to the cardiac neural crest cells. Okay. Now, the cardiac neural crest cells takes on a big responsibility. It's not just with this spiraling, it does the formation of the craniofacial bones, cartilage, the thymus, the parathyroid glands. It's also, if there's some disruption, you'll see outflow tract anomalies, even facial anomalies. Okay, so these cardiac neural crest cells, they have a big responsibility. And if there's a disruption, it can really affect the fetus in various ways. Okay, so once again, we'll see either VSDs, some septation defects, aortic arch defects, outflow tract. We're just talking about the heart, but it looks like it can affect other defects as well. Okay, other parts of the body as well. All right, so let's go back. Now, this spiraling process has an important name, and I want you to remember this because they may mention this on your boards, but it creates the aortic pulmonary septum. Okay, so it's a tongue twister, but that's part of that spiraling process that we were referring to. Okay, now this septum splits the truncus into the aorta and the main pulmonary. Okay, so that's important, very important. I mean, everything is important, but you really want this to split. You need the separation. Then these will then join to form the paths of the blood flows from the right and left ventricles. Okay, so it's very, very important process for that to happen. Now, just to go a little bit deeper, when these neural crest cells fail to migrate with these disruptions, then there are some big issues that happen. Okay, so the truncus, with that separation or that process, it takes on two important jobs. It has to septate and it has to spiral. Okay, so these are two functions that has to happen for the truncus arteriosus to do that complete split. Now, if there's septation disruption, that's going to lead to your persistent truncus arteriosus. So this happens, I mean, that's pretty self-explanatory. This happens when the aortic pulmonary septum fails to form or fails to divide. Now, the tetralogy of Fallot happens because the aortic pulmonary septum moved forward and upward. Remember, the normal process is downward and from back. Okay, so that's why I wanted you to remember that. So tetralogy is because it moved forward and upward. Okay, your double outlet right is just basically is a misalignment. Okay, so it caused the aorta to correctly align over the right, leading to both vessels originating from the right ventricle. Now, if there is a spiraling error, okay, then that's what's going to lead to your detransposition of your great vessels. Okay, so that's where that error happens. So during the spiraling process, it allows the pulmonary trunk to cross anterior into the left of the aorta. So if there's a error there, then of course that makes sense, right? That it's going to lead to parallel vessels instead. Okay. All right. So let's talk about truncus arteriosus. So when you think trunk, I always thought of a trunk of a tree, fat, like thick, you know, trunk. So truncus arteriosus is that common atrium. Remember, that's how it starts. It starts with that common atrium, also known as the truncus arteriosus. So failure of that division is going to lead to truncus arteriosus. Now there's four types, but the most common type is type 1. Remember earlier too, I mentioned with that truncus arteriosus, almost always usually we see a VSD with that process. Okay. So type 1, just to go further into type 1, is when the main pulmonary artery branches off from the truncal root and then splits into the right and left pulmonary arteries. Okay. All right. So let's talk about the transposition, the spiraling defect. Now, you may need to, I think this is very important. I'm not going to even say may. I think this is, I should have put a star, highlight. This is something you want to know the difference between the two. So with complete transposition, transposition, or D equals Dexter, the great vessels are switched. Okay. So just look at the demonstration here. So with complete transposition, the great vessels are switched. When it's congenitally corrected transposition, then the ventricles are switched. See the difference? Okay. All right. Now remember, congenitally corrected was due to that L-lupin. Okay, so that's where the ventricles are switched. This is a double discordance, but it results in a normal corrected circulation. The detransposition or the complete transposition, this is very important to pick up. I mean, both any heart defect is important to pick up, but especially the ones that's going to cause blue babies, meaning when a baby is born and they're blue, they need help immediately. So this is something that we need to catch prenatally to give these babies a chance. Okay. Now, we have some research say that the exact cause is not fully understood. Okay. So, but I mean, we know the process of how the heart is forming, so we can speculate that it's either due to the rotation of the heart's outflow tract, meaning stopping the aorta from moving into the correct position, or like we said, the spiral movement, the septum between the aorta and the pulmonary forms in a straight line, causing them to connect improperly. Okay. All right. So let's take a look at example of a D transposition. All right. So with the D transposition, it's a short click, but you can see that the pulmonary artery is coming off of the, looks like here, because this is where it's splitting. And that's what gave it away. With that pulmonary artery, you can see the split or the bifurcation of the right and left pulmonary arteries. That is coming off of the left ventricle. And then your left or your aorta is coming off of the right. Notice there is no bifurcation in that example. We could watch that again. You can see the bifurcation here. And that's how we knew that this was the example of DTGA. Okay. Now with, let's show it again one more time. With congenitally corrected, we learned that the ventricles are switched. This is where you have to remember or pay attention to your morphological markers. Okay, so with your morphological markers, you'll be able to pick up that this indeed is a moderator band. Okay, so then that moderator band is what gives away that that is the right ventricle and so forth. Okay, so I have an example. These example of the congenitally corrected, and don't pay attention to the annotations. I am pointing out And a quick note is that my system, on my ultrasound system, we have an auto annotate feature that annotates all of our pictures for us to make the process faster. In the auto annotation setting, they still label the picture of the four chamber heart incorrectly. So do not depend on your ultrasound system to pick up these morphological markers. That's for you to do. Okay. So here is an example of a normal four chamber heart. You can see normal moderator band. You can even see that insertion of tricuspid valve, highly apical, or I guess higher attachment. So this truly is a right ventricle, which you can see here demonstrated, which is clearly on the left side, connected with the left atrium. Okay. Now the left ventricle is normally more conical shape or elongated. It's apex foramen. It has a smooth surface, which you can see here in the normal demonstration. But in my picture, you see my left ventricle here is indeed connected to the right atrium. Okay. So you have to pay attention to these morphological markers. Here's the same example. It's the same heart. It's just I took away the annotation so you can see the marker. So you can see that this is indeed the moderator band. This is indeed a left atrium. You can see pulmonary veins, descending aorta. This is indeed very elongated, which is clearly the left ventricle connected to the right side instead. Okay. All right. So we're getting down to the end. Now we're at the point where we're discussing the aortic arches. Okay. Now remember from my first diagram way back when it was a tubular structure, and remember the truncus arteriosus, and remember those vessels we saw from the top. So the aortic arches are formed by 6 pairs of arteries from the distal portion of the truncus arteriosus. Okay, here's a nice demonstration of that. Perfect. Okay. All right. So from these 6 structures, so we all know we have uh, 3 vessels coming off the aortic arch usually, but just keep in mind it starts off with 6. Okay. You will need to know this for your exam. Okay. As far as what arches forms what. So you have to remember this. So your third pair of arches forms the right and left carotid. Okay. The left fourth arch equals the aorta. Your right fourth arch equals your innominate and your right subclavian artery. These are very important to remember, guys. The right sixth arch equals the right pulmonary artery, and the left sixth arch equals the left pulmonary artery and ductus arteriosus. Okay, so 3, 4, says 3, 4, and 6. Okay, so 3, 4, I'm just checking 4 and 6 arches. The other arches disappear. And looks like that's going to be, I have 1 and 2, but notice there's no 5. Okay, so 1, 2, and 5 disappear. Okay, so 1, 2, 5 disappear. 3, 4, 6 form these structures. Okay, now I pinpoint or I tag my congenital heart disease part 1 and the 3 vessel trachea view because it's going to go further into aortic arch defects. So you want to keep that in mind. Please refer back to those lessons so you can see, I guess you can see what all defects happen with the aortic arch, okay? Today, I'm just discussing the most common defect, which is the ARSA. Okay, so let me show you that. The ARSA. Now, the ARSA is the most common congenital defect of the aortic arch. Now, I had a test question on this. Okay. Now it asks me basically what was the embryological era? What went wrong? Why was an ARSA formed? Okay. So an ARSA is formed, which we learned about those vessels and what they become. The ARSA is formed when the right aortic arch regresses between the right common carotid and right subclavian arteries instead of being distal to them. Okay, so it's just all about the location of where it went wrong. And let's take a look at that. Okay, so in the normal, let's look at normal first. Okay, so in the normal arch, your right subclavian, your right common carotid is coming off of your brachiocephalic artery. So that's that first vessel. Then you have your left common carotid, then your left subclavian. Okay, so this is normal. Now, in the example of ARSA, instead, there's no right common carotid. I mean, there is a right common carotid, but the location of that subclavian, it's not branching off there. So notice, where's your brachiocephalic? Notice, because remember, the brachiocephalic trunk was there first, and then those two vessels were adjacent or on top of that. But in the case of ARSA, it's instead the right common carotid, okay? Then your left common carotid is there, your left subclavian, and then your right subclavian is that fourth vessel. It forms a fourth vessel off the aorta, and you see it kind of courses over there. It can um it can circle that trachea. So you want to it usually is asymptomatic, so it's nothing where things are required prior to delivery. But in cases, say for surgery, further on, esophagus surgery and so forth, it is important for the surgeon to know this. It is important for the surgeon to know this. So please keep that in mind, far as it's important structure um, that you want to let the surgeon know that there is a case of ARSA in that particular circumstance. Okay, so now we're getting to the venous system. Now, before I go and break down each one, I want to show you during this process between days 21 through 49, the umbilical veins, the vitelline veins, the cardinal veins, IVC, SVC, and the ductus venosus is forming. Okay. All right. So we're going to discuss those veins again that we talked about early on. Now, cardinal veins, remember, it formed the main venous drainage system of the embryo. And if there's a disruption there, it leads to some complex malformation as well as some isolated malformations. Okay. Now, just to talk about one that I commonly see is the left superior vena cava. Okay, so that's the most common variant of the thoracic venous system. And what happens there, instead of it regressing, it persists. So there's a remnant of the proximal segment of the left anterior cardinal vein. That's the era there. And so basically it results from it. It should go away, but it did not. So that's why it's persistent. So to break it down, say like if you have a test question about what went wrong, you want to pick the answer that says it results from the failure of the left anterior and common cardinal veins to regress or disappear as they normally should. Okay. All right, let's get into umbilical veins. Now, umbilical veins, they carry the oxygenated blood, the nutrients from the placenta to the fetus. We also learned that the left is what's present normally, okay? Now, the concentration of oxygen equals 80% saturated mid-gestation. Towards the end, it's about 67 to 75% oxygen saturation. What's important to remember if there is a failure to create this connection, it's a lot of complex, I want to say defects as well that we may never see. But ones that I have seen that we talked about was persistent right umbilical vein, as well as umbilical vein varix. Those are two that I commonly see all the time, actually. And so yeah, so that's the umbilical vein disruption. And ductus venosus. Now, I want to talk about this because we actually here lately had a few cases where there is absent ductus venosus. Okay. So in this case, or normally, the function of the ductus venosus is the shunt that allows the oxygenated blood from the placenta to flow to the heart and brain, bypassing that liver or the liver, and it connects the left portal vein to the IVC. Okay, that's its function. Now, there is a thing as ductus venosus agenesis, or it's absent. So it just failed to develop. So in this case, the flow still has to flow. So it's going to kind of create some abnormal umbilical portal systemic venous shunt formation. So it's going to create I guess, a pathway to somehow get the blood to the brain and so forth. And so we don't have to break this down. I don't even think you would need this for your test. I didn't have any questions on that. It's just something because here recently, we have seen several cases where it is abnormal, but it's amazing how the body still makes a way. And so I just wanted to point that out. So if you want to read that and learn more about that, that's totally fine. But as for your boards, just kind of be familiar with the abnormal process of what could go wrong. Okay, so with your Vitellin veins, same thing. This is a very rare disorder. If it did happen, it's rarely seen. It's only a few cases documented. But it's just since we're talking about embryological era, we have to just include it. Like I said, you won't need it for your exam, but just be familiar that where if there's an error, what goes wrong, and then how amazing is the body to still try to make a pathway to allow the blood to reach various parts of the baby. Okay, it's amazing. So pulmonary veins, very, very important. So with the pulmonary veins, to know the whole process, when you think of total anomalous pulmonary venous return as well as partial anomalous, once I found out how it's formed, it all made sense to me because these are two defects that I couldn't quite understand, like what went wrong. Okay, so just to break it down, pulmonary veins grow from a small bulge in the back of the left atrium. Okay, you can kind of see that in the illustration. So at first, because normally we know there's 4 pulmonary veins. But in the beginning, or as it's forming, it starts with a single common pulmonary vein. So 1. It starts with that common pulmonary vein, which then merges into that left atrium. Okay. Now, from that process, it helps create separate pulmonary veins that link up with the lungs, ensuring that blood is flowing between the lungs and the heart. Okay. Which you can see all throughout this demonstration. Now, when we go to talk about the defects, with total anomalous pulmonary venous return, there's 4 types. And so basically all four pulmonary veins fail to connect normally to the left atrium, which leads to a complete rerouting of that blood. Now with partial anomalous, partial is 1 or more, but not all. Okay, so that's the difference between those two. And with partial, these pulmonary veins, they fail to connect properly to the left atrium, causing a mixed circulation of oxygenated and deox. Now, I do want to point out here on this one, it's listing total anomalous pulmonary venous type 1, type 2, type 3, and so forth. So I just wanted to point that out as far as the various types. Once again, when you go back to lessons, congenital heart disease, part 1 and 2, this will break down these defects a little more. Okay, right now we're just discussing the embryological era. All right, we are now at the end. I do want to point out some important things to know or to remember to keep in mind for your exam. A lot of these, I guess you can say stages, you won't have to list the dates or the gestational age per se. What I did see from exam was when did the heart started beating? That was on gestational age 28, okay? And then when do placenta circulation begins? And that's around gestational age 31 to 35. So those were two key areas that may mention or ask far as gestational age at that time. Definitely be familiar with the process. So we start off with a single heart tube. Remember, so you can see that here mentioning you have your umbilical veins, your cardinal, your vitelline veins, and then it goes to what stage 2, the looping, what happens there, common atrium forms, followed by AV canals. So definitely remember these steps. Then from there, heart starts beating. From there, so please keep in mind all 4 heart chambers are formed. Then we have the 6 pairs of the aortic arches are forming lead into your pulmonary veins, then placenta circulation. Notice the placenta circulation happens after those pulmonary veins are formed. Just remember just the process. Tricuspid and V valves form, leading to your coronary arteries. Now, with your IVC, I put some important notes to keep in mind. So it says here, the IVC is formed from the posterior cardinal veins, okay, contributes to the upper segment of the IVC. The subcardinal veins form the middle portion, and the supracardinal veins develop into the lower segment of the IVC. And the reason why I pointed that out, because in cases of your interrupted IVC, if there's an error, and depending on that location, you see where the error occur. Okay, your SVC. Your SVC develops from the proximal portion of the right cardinal vein and the common cardinal vein. Okay, so I just wanted to point that out. Day 49, your interventricular septum is forming. Lastly, the aorta, aortic valve, pulmonary artery, and pulmonary valves forms day 56. Okay. All right. Another thing, please remember the embryological, I guess you could say, structures versus after birth structures. I had a question or two asking. Okay, so keep in mind. Now, it's easy for some because the name is similar to the embryological structure. So, for instance, ductus arteriosus, ligamentum arteriosum, foramen ovale, fossa ovalis, ductus venosus, ligamentum venosum. The umbilical arteries is the superior vesical arteries. Umbilical vein is now after birth known as the round ligament of the liver. Okay, so important to remember for your exam. And we are done. You made it. I really think I had so much fun learning this. And it really helped me with knowing the defects and remembering what went wrong. By me knowing what happened during the development or knowing how normally the heart develops, it's now easy to remember these heart defects. Hopefully the same for you. I am so excited because this is the last lesson for the fetal heart series. So hopefully you feel well prepared for your exam. If you have any questions, please email me. Please email me. You can find it on the head page or the YouTube channel. Please email me or send a comment. I'm always looking to answer any questions if you have a question. But keep in mind, you see my rhyme or reason for saving the embryology for the last, because I feel like it's the glue to the other lessons. This here is the glue to glue it all together and to make sense. It would have been to do this in the beginning or as lesson 1, I think it would have been a little overwhelming. But if you went through the proper lessons in order from 1 through 9, and then here we have this very last one, this one should be the glue to everything you need to know for your fetal echo boards. I wish you well, and Once again, good luck on your boards. Happy studying. Thank you.